Hello, my name is Dr. Dewan S. Raja. Today I will discuss about ptosis. What is ptosis? Ptosis is the drooping of the upper eyelid. Here is the ptosis, drooping of the upper eyelid. Usually the upper eyelid should cover a few millimeters of the iris. In drooping, it covers more than usual iris, and it may cover the pupil. What are the causes of ptosis? It may be congenital. It may be due to paralysis of the levator palpebrae superioris muscle, as in increased intracranial pressure due to intracranial hemorrhage, or due to hydrocephalus, or it may be due to any brain tumor that may lead to transtentorial herniation that may block the nerve supply to the levator palpebrae superioris muscle. The oculomotor nerve may be compressed. It may be a component of Horner syndrome, as seen in Pancoast tumor, as seen in neck injury. It may be a part of myasthenia gravis, an autoimmune disorder of the neuromuscular junction. And ptosis may be due to oculopharyngeal dystrophy, that is an autosomal dominant disorder seen in the middle-aged people, in the adult person during their middle age. Or it may be due to stroke or cerebrovascular accident in the midbrain involving the oculomotor nerve nuclei. Okay, so we'll go there. Congenital ptosis. Here is the congenital ptosis here, and it is the weakness of the levator palpebrae superioris muscle on both sides. It is usually bilateral, maybe intrauterine trauma, maybe non-specific intrauterine trauma, or lack of connection of the oculomotor nerve to the levator palpebrae superioris muscle. It may be an autosomal dominant disorder. This is the newborn attempting to elevate the upper eyelid by contracting the frontalis muscle, and it needs surgical management because it may cover the pupil, may disturb the vision. Okay. Autoimmune ptosis. This is due to an autoimmune mechanism. Usually patient is a young lady, maybe a little bit older man. In the adult, usually female has little more chance than that of the man. It is a neuromuscular dysfunction. The neurotransmitter cannot connect with that of the postsynaptic receptors because there is some antibody block the postsynaptic receptors. So acetylcholine cannot work there. Okay. So what happened? In addition to ptosis, that is the drooping of the upper eyelid, other proximal muscles are also weakened, especially the muscles at the neck region, in the pharynx, muscles of the facial expression, muscles of the upper limb, the proximal muscle, like the deltoid, maybe the triceps muscle, maybe bilateral, maybe asymmetric, but it is usually bilateral. And as the person becomes more fatigued, he will have more weakness. So in the early morning, usually people after a good sound sleep has no muscular weakness. As the day advances in the afternoon, the eyelid goes down, muscles become weaker. It can be tested by hydrophonium test, and it can be managed by newstigmine, that is an acetylcholine esterase inhibitor. Okay, so that the acetylcholine will remain here more time and it may come in contact with the receptors. So it can be managed by newstigmine, or the myasthenic gravis may be due to thymic tumor, thymoma, maybe hypertrophy of the thymus gland in some individual. In that condition, thymectomy may be the remedy for myasthenia gravis as well as ptosis. Okay, ptosis and Horner syndrome. This is a problem of the sympathetic nerve to the head and neck. The sympathetic innervation to the head and neck is cut. Okay, suppose this is the pre-ganglionic sympathetic fiber going to the superior cervical sympathetic ganglion. Then post-ganglionic fiber will go to the dilator pupillary muscle, and it also go to the superior tarsal muscle or molar muscle. That muscle is very close to the levator palpebrae superioris. There is a smooth muscle. We must remember that levator palpebrae superioris muscle is a skeletal muscle, and ptosis due to paralysis of the levator palpebrae superioris muscle is more prominent than that of the paralysis due to sympathetic nerve supply disruption to the superior tarsal muscle or molar muscle. In that condition, we will get partial ptosis due to lack of nerve supply to the superior tarsal or the molar muscle, not the levator palpebrae superioris here in Horner syndrome. Here is the muscle is the superior tarsal muscle or molar muscle. What are other features of Horner syndrome? We'll get partial ptosis, also called pseudotosis. We'll get meiosis. People will be constricted. Why it is constricted? Because sympathetic nerve supplies the dilator pupillae, that will not work. So the sphincter pupillae will take upper hand. So sphincter pupillae will work, dilator pupillae will not work. So there will be constriction of the pupil. We call it meiosis. There will be anhidrosis because lack of nerve supplies to the sweat gland. Sweat gland depends on the innervation by the sympathetic nerves. Okay, the postganglionic sympathetic nerve, if there is lack of nerve supply to the sweat gland, will lead to lack of sweating. This side we have the Horner syndrome. So people constricted, ptosis, it is partial ptosis, and the affected part seems to be red due to lack of sympathetic innervation. There will be no vasoconstriction. So there will be blood vessel dilated, so it will be red color. And eye will seems to be sink back. Maybe the soft tissue around the orbit will be atrophied due to lack of innervation by the sympathetic nerve fibers. So this is the part of Horner syndrome, and ptosis is an important part of Horner syndrome. But here ptosis is partial ptosis. It is not total ptosis. Okay. What is the treatment of ptosis? Treatment according to the cause. If it is congenital, then certainly surgical management is essential. If it is due to Pancoast tumor, as in Horner syndrome, so we may have Horner syndrome due to Pancoast tumor or disruption of sympathetic innervation, maybe any type of neck injury or head injury may also lead to Horner syndrome and ptosis. So treatment according to the cause. It may be management of the Pancoast tumor or head or neck injury should be managed properly. Okay, but if it is essential, it may be required to consult with an oculofacial plastic surgeon to elevate the upper eyelid. And that's all about the ptosis. If you have any question, please feel free to ask me. Please share the information with your friends. And please support my channel. Please subscribe me. And have a nice day. Bye now.